Yes, now we can hear you.
All right. Okay. I'm just going to dive straight into it. So I'm from the Singapore General Hospital Department of Urology, and I'm going to talk to you today about, I was asked by Vinit to talk about when and why I do focal therapy for prostate cancer. And I was asked to give a second talk on cryotherapy, dead or alive. So I think fortunately for everyone, I've combined these two into one talk. So we should be able to address all the issues with one talk. So to dive straight into it, I think this has always fascinated me about prostate cancer. Regarding prostate cancer, as Willard Whitmore famously said, if treatment is necessary, is it possible? And if it is possible, is it actually necessary? He's alluding to the fact that, we can be very aggressive about treatment, but if the cancer biology is unfavorable, it would be impossible to cure the patient no matter how radical a surgery we did. At the same time, if the tumor was not aggressive, the cancer biology was non-aggressive, then no matter what treatment we did, or even if perhaps if we did no treatment, then the outcome would be the same because it's potentially a low-grade or low-risk disease. So that has pretty much colored my perception on prostate cancer. This is a slide on prevalence of prostate cancer in Asia. I was very fascinated by this slide when looking at this data, that the blue columns, which show the incidence of prostate cancer compared to the mortality rate of prostate cancer in red, it's very similar for many countries in Asia. There are some countries with a closer mortality to incidence rate, but in many Asian countries, there is a large excess of incidence from mortality, and that's similar to what's seen frequently in the West, where only 1 in 6 men who are diagnosed with prostate cancer eventually die from it. So we've heard about standard curative treatments for localized prostate cancer. We've had excellent talks on radical prostatectomy. We've heard about radiation therapy, and these are the tried and tested ways to treat prostate cancer. We know that these work very well, have a very long track record, but we also know that these treatments are associated with many side effects. We just had an excellent talk on, what are the 10 commandments to try to minimize these and to maximize, our having good outcomes with radical prostatectomy. But having said that, even then, if we look at the statistics, there are people who have side effects. And I mean, with prostatectomy, one could get incontinence, of which 5% are permanent, erectile dysfunction, whether it's permanent or temporary, other complications of surgery, and the radiation, as scientists who come into hospital for multiple bladder washouts, or they have radiation proctitis. And with time, they can even have a risk of secondary malignancy. So with prostate cancer, if we break down what Whitmore said, we can actually look at it in terms of a spectrum of aggressiveness. We have very indolent cancers, where perhaps the term over-treatment has been used very widely. These are cancers we think are unlikely to harm people, or we can have very aggressive cancers which probably will harm people. So those that are indolent typically tend to be low grade or low stage. They may grow slowly over many years or decades, whereas the aggressive cancers, tend to be high grade and high stage. They can grow rapidly and spread over months to a few years. So could we adapt our treatments, our various treatments to the spectrum of aggressiveness? And that's where, we have been putting a lot of men on active surveillance. Over the years in SGH now, about 50% of men who are being diagnosed with low-risk prostate cancer have been on surveillance in the last 10 years. And those who have aggressive cancers, can we do MRIs pre-biopsy and do a good targeted biopsy, identify these early for radical treatment, before they progress on to become oligometastatic or metastatic disease. And this is where there's a spot in between, where you have men who potentially have higher grade cancer, but perhaps in the low stage. And is this where focal therapy can make a difference and continue to maximize our oncological outcomes while maintaining the functional outcomes for men? The aim of focal therapy is to eliminate the cancer focus, but yet preserve the uninvolved tissue in an attempt to maintain a patient's quality of life. So this cartoon shows examples where the tumor is in orange, and the ablation, which is treatment with a margin, is circled around the orange tumor. These are various schemata looking at targeted ablation, quadrant ablation, anterior ablation, and so on. The idea being to just treat the tumor with a margin, and then can we spare the other critical structures, such as the neurovascular bundle or the urethral sphincter. So let's have a look at the contemporary consensus on patient selection for focal therapy. So these are consensus that have been made over the last 10 years, since 2010. Initial consensus, if you look at the goal of the consensus, the goal of focal therapy then was to eradicate all cancer. But as time progressed and we have a greater understanding of the biology of prostate cancer, it became eradication of only the clinically significant cancer. These are the cancers that are going to impact the oncological course of the patient. And if you look at the latest consensus led by Gross, he actually stated that, and this group actually stated that the aim would be to completely ablate the cancer and to delay or altogether avoid radical therapy, perhaps indefinitely, through treatment, retreatment, and surveillance. Because if you can imagine that some low-grade cancer that remains could potentially be put on surveillance. So this is a change in the paradigm, and I think that patients are asking for treatments with better quality of life. I mean, we heard that in the field of BPH earlier today, and it's the same for prostate cancer, if we can offer them the same oncological control. So the question is really, can we offer them the same oncological control? So how can we achieve success in focal therapy? To me, these are the 5 tenets that must hold true. Once we can achieve this, focal therapy could potentially be a successful treatment for prostate cancer. Firstly, we must be able to accurately stage and grade. Then we must be able to determine the position of the cancer intraprostatically. We must be able to ablate the cancer adequately with a low rate of complications. That is the promise of a minimally invasive treatment. And we also must be able to preserve sexual and urinary function. And last, we must be able to detect and salvage recurrences when they occur. We don't want men to become metastatic because they have opted for perhaps a lesser treatment, if you will. So the first question is, how many prostate cancers are really unifocal? So I looked back and created this very busy slide, which looks at all the prostatectomy series that have been submitted for pathological examination since 1992. You just need to look at that column that says % unifocal. And you can see that the number of, the prevalence of cases that have truly unifocal cancer can range from something as low as 8.9% to something like 66%. Suffice to say that not every man will have a unifocal cancer. In fact, most patients have multifocal prostate cancer. If so, why should we be doing focal therapy? Well, there is some supporting data now on this index lesion hypothesis and the origin of prostate cancer. You may have heard of the term index lesion, which has become more popular in this era of targeted biopsy. And the data suggests that most of the time, grade and stage is determined by the index lesion, which is the largest or most aggressive lesion within the prostate. Most of the tumor volume is contributed by the index lesion. And majority of satellite tumors tend to be small and low grade. And there are also genetic studies to suggest a monoclonal origin of metastatic or lethal prostate cancer. Whether these come from the index lesion remains to be tested. But given this data and the fact that many satellite lesions are of low grade cancer, 3+3, perhaps suitable for active surveillance, if we break down this table, which I showed you earlier, and look at percentage unifocal with satellite tumors that are less than 0.5 mils. I mean, in the spirit of Stamey's criteria for insignificant prostate cancer, those satellite lesions would probably be insignificant in terms of their biology. So the percentage that are unifocal with these very small satellite tumors increases from somewhere to 33 to up to 93%. So there exist these tumors out there that potentially could be treated with focal therapy, and these men could be spared the side effects of radical treatment. The next question is, of course, can we find them? So with the advent of MRI, there's now a lot of data. And looking at some of the earlier studies in 2015, comparing MRI to whole mount pathology, Barco could identify 95% of index lesions in 135 men. And these are patients who all eventually underwent radical prostatectomy. Jesse Lee did a more detailed analysis, and he found that those with larger tumors, higher Gleason scores, and index versus non-index lesions tended to be discovered by MRI. Of course, there's also the PROMISE trial, which was a paired comparison of MRI and TRUST to transperineal mapping biopsy. And this tells us that while MRI seems to have a lot of promise, the negative predictive value of MRI is only in the region of 76 to 89%, depending on your definition of clinically significant. If you use a very strict criteria, like anything that is 3+4 or more is clinically significant, then the negative predictive value is 76%. If you use a more loose criteria, like you say that it's got to be 4+3, more than 3 cores, then the negative predictive value is higher at 89%. But essentially, you can see that MRI is not yet the holy grail for which we can say that there really is no other cancer in the prostate than what is the index lesion that is seen. Well, targeted biopsies have been able to have a concordance rate of up to 85% for Gleason 3+4. And these are the set of patients that are most likely to benefit from focal therapy. But because of the failings of MRI, or rather the imperfections rather than failings, we've been doing transperineal fusion biopsies paired together with saturation biopsies to better assess the prostate. And this is an image of, a cartoon of the transperineal biopsy that we're doing in SGH based on the BioBot Mona Lisa, which was developed at SGH and worked on by all the urologists in Singapore, as you heard earlier from Edmund as well. Next, I move on to some contemporary focal therapy outcomes. So I've shown you that, MRI, while there are some imperfections, we're now able to identify the lesions, do targeted biopsies on them. And if you match up with a saturation biopsy or a mapping sort of biopsy, you can assess the area of the prostate that, MRI calls negative if you really want to make sure there's no cancer there. How about the outcomes of focal therapy in published literature? Now, most of these are very small series. We've identified 25 focal therapy series using a variety of treatment methods. There's cryotherapy, which I'll share more about. That's what I'm doing. HIFU, high intensity focused ultrasound, laser, IRE, which is irreversible electroporation, also known as nanoknife, basically 2 electrodes that electrocute the cells in between. VTP is vascular targeted phototherapy, which is a sort of laser activating a chemical substance, a podophyllin, essentially, that's injected intravascularly. So there are all these different types of focal therapy, but essentially to me, they're all the same. We ablate tissue or we kill the cells in the target zone. So these are a summary of these focal therapy series. And you can see over time, if you look at the axis on the y-axis shows a proportion of intermediate and high-risk cancers being treated. More and more intermediate and high-risk cancers are being treated with focal therapy as time goes on. Like I mentioned earlier, you can see that most of these series are very small. The size of the bubbles tell you the N number. Most of these are a series of less than 50 patients. And the 2 large bubbles are those with a huge retrospective series. These are about 500 patients that have undergone HIFU or cryo in the cold registry. So the proportion of intermediate and high-grade cancers being treated is increasing. So the oncological outcomes of focal therapy are difficult to assess presently. And the reason is because to develop a tried and tested track record like prostatectomy or radiation therapy, one would probably need to follow patients for 20 or 30 years. I mean, we know that prostate cancer is a slow-growing cancer. So one way to look at the oncological outcomes is to compare focal therapy to someone who's on active surveillance. When you rebiopsy them at 1 year or 6 months, what do you find? Is there any cancer left behind? And this is an aggregation of series, which there are about 15 series in which there was a mandatory rebiopsy. Where there are focal therapy series that only rebiopsy patients when the PSA is rising, I don't think that tells us the true prevalence of cancer after focal therapy. So those studies that are represented on this chart are studies where there was a mandatory rebiopsy at 6 to 12 months. That means that even if the PSA was stable, the MRI was normal, they underwent a rebiopsy. And you can look at the columns here that tell you about infield. Well, there are 2 types of recurrence that can occur. If you look at the cartoon, an infield recurrence refers to recurrence of cancer within the treated zone of the prostate, and an outfield recurrence refers to recurrence of cancer outside the treated zone. So if you recur in the treated zone, it's likely that maybe you had incomplete ablation or some kind of technical problem. If you had a recurrence outside the treated zone, then one possibility is that the cancer was missed, it's a failure of selection, or one could have a de novo cancer arising, which is unlikely at 6 to 12 months. So if we look at the two bar charts on the left, these are infield cancers, and the two bar charts on the right are outfield cancer recurrences. Now, the one on the extreme left, the blue one, is for infield any cancer recurrence, whereas the one in pink is an infield CSD, which means clinically significant disease. So you can see that the recurrence rates of clinically significant disease are much lower than that of infield any cancer. And that's the same for outfield recurrences as well. The green bar is outfield any cancer, whereas the yellow box shows outfield clinically significant disease. Well, the medians for these for clinically significant disease recurrence within the treated zone is about 10%, and that's the same for outfield clinically significant disease. So you do get a failure rate of something that is about 10 to 20%. And this is what I tell my patients when they want to know about focal therapy and they want to know about the oncological outcomes. It's not as perfect as what you will get with a prostatectomy or radiation therapy, but this is a price to be paid. And you know, for someone going on focal therapy, I think a mandatory rebiopsy is really important in order to try to identify any recurrence early so that they might be salvaged by the mainstream treatment methods. So why do some of these recurrences occur? I mean, recurrences in the ablated zone, in the treated zone, are particularly worrying. I mean, that tells you that, you know, perhaps there is a miss or a technical error. And this is an example of a study of a laser focal therapy where all men underwent prostatectomy after treatment, basically an ablate and resect study, as we call it in the field. So this patient actually had treatment within the MRI scanner. So he had the laser focal therapy, and can see that red spot in the top left panel, which is very red. You can see they achieved temperatures of excess of 117 degrees. And if you look at the panel on the bottom left, that shows the follow-up MRI, which is there's a defect over there in the prostate. And then if you look again at the prostatectomy specimen, that defect with dead tissue is still there, circled in green, but there's also tumor that is circled in blue. Essentially, there's a lot of tumor at the margin. And the question is, why wasn't this known? Why wasn't this detected? So marginal recurrence is something that can lead to treatment failure in focal therapy. And one of the reasons is because, you know, we're using MRI now to detect cancers, and it's really good at that. But at the same time, we're using MRI to estimate the tumor volume for adequate ablation. And this study by Priester shows very nicely that in the anterior, posterior, and left-right axis, there's sometimes an offset of up to 8 millimeters. The tumor can extend up to 8 millimeters outside of where the MRI ends off. And in the base to apex, it can be up to 10 millimeters. So MRI is underestimating the tumors. And, you know, we looked at our local series to look at why this was so. So we basically looked back at all our radical prostatectomy specimens and looked at the MRIs that were done for these patients. And what we went on further to do was that we had a hypothesis that, you know, MRI is really good at picking up high-grade cancers, but not low-grade cancers. So we marked high-grade and low-grade differently. You can see the prostatectomy specimens whole mount at the bottom of the slide. And those low-grade areas were marked in black. The high-grade areas were marked in blue. High-grade meaning anything that was Gleason grade 4 or 5. And low-grade meaning anything Gleason grade 3. So if we look at those two panels there on the slide that says all cancer and component grade 4 or 5, basically for all cancer, this means we take all cancer. And the green dots are where, you know, the MRI and the pathological lesion have a difference. Basically, when the green dots are above the blue bar, it means that MRI is overestimating the tumor, which is good. But if the green dots are below the blue bar, that means that MRI is underestimating the tumor, which is not so good. But if you look at just the component grade 4 or 5, and remember, these are the cancers that you're trying to kill, you can see that most of the yellow dots are actually falling above the blue bar, which means that MRI is overestimating them. And if you drew a margin basically the dotted orange line at -100. That means taking a 5 millimeter margin, you would actually get most of these grade 4 or grade 5 cancers. So I think this is where the margin is really important in making sure that the ablation is successful. And this is one example of a patient who underwent focal cryoablation. You can see that tumor is marked there in red. And this is an animation that shows 4 needles that were put in the anterior zone where the tumor is. If you look at the panel on the bottom left, that will show you the ice ball. I'm not sure if you guys can see the animation clearly, but the ice ball is essentially advancing. So the edge of the ice is at 0 degrees Celsius. And, we know exactly how much tumor is being treated so that we can be really sure of our margin. There are also temperature probes that are placed in situ. So if you look at the bottom right panel, there's a temperature probe marked E, which is at the apex, and the apical temperature is at -37 degrees. And that's a lethal temperature. Anything less than -20 is lethal. And temperature sensor B is at the right neurovascular bundle, and F at the external sphincter. And these are both at normal body temperature. So you can see that we're preserving the neurovascular bundle there and the external sphincter. There is one randomized trial comparing focal therapy using VTP versus active surveillance. And these included only men with low-risk prostate cancer. They were criticized for this, but they did show a positive outcome. They looked at the rate of patients who needed to undergo radical therapy, and they found that there was a 70% risk reduction in needing radical therapy after patients were treated with focal therapy compared to men who are on active surveillance alone. So this was one study that shows the positive oncological outcome. I think that's the only randomized trial that I showed for focal therapy. So what about the functional outcomes? Again, there are no randomized trials in this arena. There are 3 matched comparisons that are in the literature now, comparing focal cryo versus whole gland cryo, and one study comparing focal IRE, which is irreversible electroporation against radical prostatectomy. So essentially, all 3 comparisons show that potency rates were much better when only part of the gland was treated compared to the whole gland. So in SGH, we had an experience with focal therapy using in-bore MR-guided focused ultrasound, basically a HIFU that was applied in an in-bore MRI. So we did a 2-year follow-up of a phase 1 trial, and we published this paper. Essentially, patients were treated within the MRI machine with a transrectal probe applying HIFU. And this was one patient, 68-year-old retired engineer. This was a pilot study, so we treated 3 + 3. We wouldn't do that today. Just single core, PSA 7.4. You can see that's marked in red on the biopsy map. And this is his intra-procedural treatment. The beam is basically focused on that corner of the prostate gland. And post-treatment, you can see the red arrow shows that cavity on the MRI. So that area was successfully treated. So our paper was primarily geared to looking at functional outcomes, and we showed that it was a safe procedure. There was essentially no significant change in any of the 6 domains. We used the EPIC questionnaire after treatment, so their functional outcomes were all maintained. But one of the drawbacks of this kind of treatment was that it took a long time. Basically, these patients were in the scanner for about 4 to 5 hours, so it was not ideal. And that's why we've moved on to using cryotherapy, which I'll show again some pictures later. Just to wrap up on the complications of focal therapy, basically in the literature, these are all the studies with complications that are reported. Basically, no grade 4 or 5 complications. Most of the complications reported in the literature are grade 1 and grade 2 complications, with a small smattering of grade 3, presumably those who needed interventions such as a catheterization or bladder neck incision, which are very low in number. Follow-up after focal therapy. So we're getting towards the last tenet. Are we able to follow up these patients effectively? The problem is that in imaging, the experience remains very limited. We can do MRIs, but our radiologists are not good at reading these. So there's obviously a learning curve. There was a study that showed that contrast-enhanced ultrasound may be comparable to MRI for early assessment of the treated zone. Essentially, if it shows non-perfusion, that's good. But I think that biopsy remains the gold standard of monitoring post-treatment. So it's as if these guys are on active surveillance. They need to be rebiopsied. Some medium-term outcomes are after focal or hemi-gland HIFU, which essentially show that those with a higher Gleason score will have a higher chance of recurrence. So those patients may need to be followed more carefully. Because of the lack of evidence in this area, we actually got together to do another consensus meeting on what should be the follow-up after focal therapy. We got together in Kyoto last year to do this. And this is something that we came up with that everyone could accept. Basically, PSA monitoring, because it's an easy test to do. We know that PSA is not reliable after focal therapy because there's still a large area of gland untreated. So those prostate cells continue to produce PSA. Imaging we thought that should be done at 6 months and then once 12 months subsequently, and afterwards to be on a per institutional active surveillance protocol, or unless there was some trigger. Biopsy, we thought that men should get an MRI targeted biopsy at 6 to 12 months and a systematic biopsy as well. And again, 1 year after treatment and subsequently as per institutional active surveillance protocol, and to follow up on their functional outcomes. So the last part is, can we actually salvage these people? What if they recur after focal therapy? I mean, we can do a very nice minimally invasive procedure. So we've done that. And now, the patient comes back 1 year later, there's still cancer. So what are we going to tell him? Is he out of options? Must he go for radiation treatment only? Or can he actually get a radical prostatectomy? And this is a series that's been put together by the Monsoori group. And they have the largest series currently. They have treated nearly 70 men with a salvage radical prostatectomy after focal therapy. And they didn't find that there was any increase in terms of complication rates or any detriment to the functional outcome after robotic prostatectomy. But keep in mind that these are experts. So to put it all together, where are we today? Why am I doing it? Well, I think that we can accurately stage and grade cancers. There's up to 85% grade concordance, as I showed you. We are able to identify the intraprostatic position 95% of the time. There's some risk of a missed clinically significant disease. That's something to know about. We can ablate prostate cancer adequately with a low rate of complications. It's largely dependent on imaging, expertise, ablation modality. And there's a high rate of continence and good rate of potency after treatment. There is still limited data regarding post-ablation imaging, and I think a mandatory rebiopsy is necessary. There's limited data regarding salvage therapy, so I think that's going to depend on your institution. And so that's why the latest EAU guidelines say that we should still only offer focal therapy within a clinical trial setting, and that's at the bottom there. And that's what we have done at Singapore General Hospital. So moving on with our experience in prostate biopsy, now we have a grant open and recruiting for a phase 2 trial of focal cryotherapy. For reasons that I mentioned, I like the cryotherapy because we can see the edge of the ice ball clearly. We can do better with the margins. It's also quite a quick procedure. It takes about 1 hour, day surgery. We're including patients with a maximum of 2 lesions, low volume, less than 1.5. But we were trying to push the envelope. We're including Gleason less than 8 cancers, PSA less than 15. We know that those with low risk cancer, 3+3, probably don't need to be treated. So we're trying to include patients with intermediate risk disease and pushing into 4+4 with a very low volume, and after ascertaining that there's no cancer elsewhere. It's done as a day procedure. We follow them up for 1, 3, 6, and 12 months with functional outcome questionnaires. And we do a mandatory biopsy at 12 months. So we're aiming to recruit 30 patients. We've done 24 patients so far. And I was going to show you a little bit about how we do this. So just bear with me for the last part. This one is a 72-year-old gentleman who presented to us due to his age. He didn't want to go for radiation. He didn't want a prostatectomy either. So we did this for him. This was the 2 lesions seen in the right peripheral zone and another in the left central medial peripheral zone. We did a targeted biopsy followed by a saturation biopsy, as we always do, to make sure that there's no cancer elsewhere. This is what we found. The green cores are Gleason 3+3 on targeted biopsy. But on a saturation biopsy, we found this Gleason 3+4. So there was this small area of intermediate risk disease. There was also 3+3 on the other side, on the left side, as you can see. So we ended up treating that also. So this was our setup, how we set up our operating theater. Patients in lithotomy position. We have that biplanar ultrasound probe there under general anesthesia. There's a urethral warming catheter, which is important to protect the urethra. Transrectal ultrasound. And this is the cryotherapy machine, visual eye system with the argon gas. And here we are testing the cryoprobes before we put it into the patient to check for any air embolisms. It's important to test this before you put it into the patient. And you can see the freeze and thaw there is working well. So this is us inserting the probes under ultrasound guidance. You can see that we use a sagittal view and transverse view to make sure that we know the 3D position of the probes. There's a second probe going in because you remember there was more cancer on the right side. We were going to treat that part. And we also ended up putting one on the left side in that medial peripheral zone there. We're just going to give that a quick freeze because that's 3+3. We were going to try to render him cancer free since we were there. So this was a planning schema, we put it in, we planned for the ice ball to be over there. We also put in temperature probes. So this is one that's at the right neurovascular bundle, as you can see. We put one in the denonvillar fascia between the rectum and the prostate because rectal urethral fistula is a known complication. So we want to be especially careful there. That's us advancing that in carefully. And then another one, which is at the urethral sphincter, temperature probe. So make sure that the sphincter is at remains at a body temperature. So this shows you where we are putting those probes, those blue ice probes that are in the right side and one on the left side, and then the temperature probe. And this is where we think the lesions are based on our combined targeted and saturation biopsy. And so this is how we're going to treat the patient. Yeah, so here, because that medial one was near the rectum, we did some hydrodissection, basically injected some saline there. It's temporary and goes away after a short while. Before we start, we do a cystoscopy, make sure that there were no probes traversing the urethra. Then we put in a urethral warming catheter. So this cycles warm water through the urethra in this catheter to make sure the urethra remains safe. That also means that there's about a 5 mm zone where you don't get a kill around the urethra. So that's important to know because if there's a cancer that's very near the urethra, probably not suitable for cryotherapy. And here's us treating the patient. You can see that ice ball forming in the first cryo probe. And as it gets near the second probe, remember we put 2 on the right side, we will start the freezing there. So you can see on the sagittal view, you can see that ice ball there. So the ice edge, which is at 0 degrees, actually it's non-lethal because you need to go about 5 mm behind the 0 degree ice edge to be where the lethal temperature is, and that's anything less than -20. So this, we start freezing with the second probe, and you can see that that kind of supercharges it. That kind of expands to near the posterior zone of the prostate already. And that's where we start looking at the rectal temperatures to make sure that's okay. So we're monitoring the temperatures here. You can see that these are all still decent temperatures, reaching a nadir of 7 for the rectum. So that's very safe. That's where the denonvillar fascia temperature probe is. And that continues to drop. We'll accept it going down to about 0 degrees because, like I said, that's non-lethal. And that's how the ablation zone is going to cover what we've discovered on MRI and the biopsy. This is the second ice ball that on the left side where there was that 3+3. We're just going to do a quick freeze there, nothing too aggressive. And once that's done, we thaw it. So we do this for 2 cycles. This is the second cycle already. So 2 freeze thaw cycles is the standard. And this was the oncological response for this patient. By the 3rd month, his PSA had dropped down to 0.9, which made us very happy. So that was good. But he's of course set for a biopsy at 12 months. We haven't done it for this guy yet. This was his pre and post focal therapy quality of life scores, you can see that most of these were preserved. There was very little change before and after focal therapy based on the EPIC questionnaire. And the preliminary rebiopsy outcomes is that we've got 4 patients who completed 1 year. So these all had intermediate risk prostate cancer. All the patients had no MRI enhancement or suspicious lesions within the ablation zone. 2 had negative biopsies. 1 had 1 out of 39 calls, 3 plus 3, 5%. Another one had 3 out of 46 calls, 3 plus 3, 5%. So these both will go on active surveillance. So I think we managed to help these guys avoid radical treatment, which is what they wanted, and to go on surveillance. Basically, they were intermediate risk, and now we returned them to the surveillance pool. So I think there's this value for these patients with very limited, intermediate or even a little bit of high risk disease. So this is where I'll end. And of course, many thanks to my department for sending me on fellowship in Duke University, to learn how to do this, to learn focal therapy from Dr. Thomas Palasic, who was my mentor over there and a giant in the field of focal therapy. And here's where we came back, and many thanks to the whole department for supporting me. You can see they're all here to see the first case doing the first ice ball in Singapore General Hospital. And I would also like to thank many of my residents who helped me in the projects that I showed, Dr. Edwin Aslim, Dr. Tan Yu Guang for helping me with the video, and all the others. So thank you very much.
Thank you, K-Jack. So that's been a very interesting talk. I think most of us have got zero experience in this. And it's nice to see it being done in such a systematic way, because all we know is we're sticking a probe and we're freezing it, but we don't know the technical, how technical it is. And thanks for enlightening us. There are a few questions which people are asking. Rectal fistula, is that a concern or not?
So traditionally with cryotherapy, it is a concern. In the days where people use liquid nitrogen, it was particularly a concern. But today with more temperature monitoring, the reported rates in literature for whole gland cryotherapy is about 2%. And in focal therapy, it's even less than that. So personally, both here and in Duke, I haven't experienced one. Thank goodness, I hope never to. But I imagine if you're ablating something that's very close to the posterior, very close to the rectum, then one must take great care. Sometimes those that are very posterior, perhaps HIFU is a better technique, because HIFU is transrectal and the energy is directed transrectally. So that's one consideration.
Right, so that segues very nicely into the next question, which you have nicely said that cryo versus laser versus photodynamic is about the same, but you've chosen cryo. So,
yeah.
Right? So you do think that cryo is better. I'm going to call you on that.
So I've had experience, I have had the fortune of having experience. I think it was Professor Christopher Cheng's initial trial on MR-guided HIFU that I referred to. So we had experience with HIFU. The problem with HIFU technology back then in 2013 was that it took a long time. Like I said, each case took about 4 to 5 hours. So that was not very optimal. With cryotherapy, the added advantage is, of course, the margin. As I've shown, there's a lot of failure in the ablation because of the margin. So it allows us to really take care of the margin. But I think what you're alluding to is how do we select between all these kind of different treatments, different modalities? And I think that the quick and dirty answer is, of course, what you are most comfortable with, just like all surgical techniques. So the group at Montsouris, Eric Barre and Rafael Sanchez Salas, they've come up with what they call an a la carte a way of selecting. There, because their expertise is in focal therapy, they have access to, for example, cryo, HIFU, and also focal brachytherapy. So they worked out a system where for them, for posterior tumors, they would prefer HIFU. For more anterior tumors, they would prefer cryotherapy. But
so
I think
more personalized prostate cancer treatment kind of.
That's right. So essentially the right tool for the job. You want to, patient comes to you with a tumor in the prostate, you look at it and you say, HIFU is the best, or cryo is the best, or hey, prostatectomy is the best. I'm telling a lot of patients that because they want to enroll on the trial and they're not suitable.
Okay, so 2 last questions.
Yeah.
Choline MRI spectroscopy for post-op follow-up. Any role in that for accuracy reasons, really? Because you alluded to the issue.
Yeah, no evidence for that. Spectroscopy has fallen out of favor. If talking about MR spectroscopy, that has really fallen out of favor because of it's difficult to do and interpret. But I don't think there's any evidence for use of that in post-focal therapy. But hey, I would love to study it. So if you are into that, for me, we'll collaborate.
Okay, last one, ADT, role of ADT and outcomes of focal therapy. Anybody, any information?
I think, of course, if you give ADT, the patients do not get what we call a PSA recurrence. Their PSA won't go up because you've treated them with ADT. But I think if you did focal therapy because you wanted to, spare the nerves and give them their sexual function, then it doesn't really make sense to do ADT.
Right.
If, the tumor was such that you needed to give ADT to treat it, perhaps focal was not the right choice for that particular patient. Yeah.
Okay, good response. So thank you very much, KJ. I think you've answered most of the questions that people have asked. I think some of the questions were asked in a bit early where you've actually covered them, like, the follow-up protocols, which was very enlightening. It's not just follow-up in one modality, but multiple. So thank you very much. I'd like to thank everybody for staying till the bitter end. It's been 4 hours. Yeah, almost 4 hours. We almost did 4 hours, but we've all done well. Thank you all for staying. Thank you to the speakers for all your excellent talks. It's been very enlightening being the moderator. So thank you very much. And I'm going to hand it back to Vinit to close the session. Vinit.
First of all, I would like to thank you, Mr. Heng. Some stamina you have to sustain 4 hours of taking all the questions. I'm surrounded by my laptop, desktop, my son's computer, and everything here trying to collate the questions. So thank you, KJ, first, because you waited all this time for your talk. It was super enlightening. It's always interesting to see how focal therapy is really taking momentum now. Personal thanks to True, Vikram and his team for allowing us to use the platform, Alto and Nitish Jain for allowing us to use the Facebook platform, all the friends in China, Mongolia, and Middle East and Africa who've been mini relayers and series. It's been an overwhelming response of having almost 400 people at one point of time. As far as I can count, it's about 22 to 23 countries. The speakers, the participants have done fantastic presentations. So have a great weekend. This is the longest I've ever run a webinar for 4 hours, and people have stayed. I've had to, unfortunately, not be able to answer quite a few questions. I'm not too sure, but I think we've hit like 200-300 questions in this. But thank you once again, and have a good day. And yeah, thanks for the participation.